Welcome to Raaonline. I am Dr. Venkatakrishnan, Professor of Medicine. We will be discussing congestive cardiac failure, the clinical features, pathophysiology, how we are going to assess and manage a cardiac failure. We will be stressing upon important aspects, reinforce specific topics with cardiac failure with regard to classification, clinical features and management. What is the pathophysiology? Why heart failure occurs, which we always know, any structural or functional abnormality which impairs either the pumping or filling, systolic failure or a diastolic failure. This is as simple as that. What happens, a vicious cycle of congestive heart failure, what happens when there is a LV dysfunction? What happens is decreases cardiac output, which decreases the BP, decreases renal perfusion. In turn, which stimulates the release of renin, converts angiotensin to angiotensin II, stimulates aldosterone secretion, which causes retention of water, sodium and increased filling pressure. This we know. Definitely, if you know this pathophysiology, we can target angiotensin, we can target aldosterone and we can target specific drugs which are in use. We have starting with ARNI and BNP analogues. What are the indications? With this pathophysiology, it becomes easy for us to learn the treatment also. What are the types of heart failure? This is usually asked. Low output, high output and right ventricular failure, left ventricular failure. Low output, we always know, that's definitely pathophysiology. There is a decreased cardiac output in systolic heart failure. Diastolic, elevated left and right and end diastolic pressures is elevated. LVEF is normal. Systolic ejection fraction may be normal. High output failure, most common if you see is anemia. Others, hyperthyroidism, beriberi, carcinoid, AV fistulas, Paget's disease, and we all know what are the causes of high output cardiac failure. Right ventricular failure, isolated right ventricular failure is not a common condition. Is seen with isolated pulmonary hypertension or large RV infarctions. So, pulmonary hypertension isolated can occur with pulmonary thromboembolism, chronic pulmonary thromboembolism producing pulmonary hypertension and right ventricular failure. Low output cardiac failure, what are the causes? Systolic dysfunction, diastolic dysfunction. Systolic dysfunction we all know, either it is a coronary artery disease or a dilated cardiomyopathy. Ischemic heart disease, most of them in elderly, dilated cardiomyopathy is due to ischemic cause. Others, HIV, connective tissue disorder, alcohol, drug related, doxorubicin. So, before doxorubicin, we all work up for a cardiac function. HIV also is a rare cause of cardiomyopathy, but there can be enhanced atherosclerosis and coronary artery disease which is seen with HIV. Hypertension, valvular heart disease, definitely systolic dysfunction, valvular heart specifically aortic stenosis. Diastolic dysfunction, this is a tough topic, but we should know what are the causes of diastolic dysfunction. Most common if you see any patient, you do echo, there is a LV diastolic dysfunction, that is hypertensive, all hypertensive patients because of the stiff ventricle. Impaired relaxation. Hypertrophic obstructive cardiomyopathy, the definition now is IHSS, that is idiopathic hypertrophic subaortic stenosis. And restrictive cardiomyopathy, we get in amyloidosis, other infiltrative disorders, which is not common. What is the clinical presentation of cardiac failure? If you see the specific for right heart failure, specific for left heart failure. Left heart failure symptoms. Initial symptom is paroxysmal nocturnal dyspnea, followed by orthopnea. We know the pathophysiology of paroxysmal nocturnal dyspnea. Sympathetic drive is reduced during sleep. There is a decrease. There is a demand which is increased. What happens is the heart compensates by increasing the heart rate to maintain a good flow. In night, the sympathetic activity is decreased and it causes PND. Even with a reduced sympathetic drive, a healthy adult without cardiac problem can manage without any symptom. Others, edema, hepatic congestion, ascites is congestive cardiac failure, right heart failure. Reduction in cardiac output, fatigue and weakness. Patient may complain of oliguria because of decreased renal perfusion. Syncope also is a manifestation of decreased cerebral perfusion.